Perfect. So welcome everyone to the intersection of prevention and recovery. Today we're with Carol Oliver and soon hopefully Hanir Hernandez. We're just having some troubles getting him logged in. We can go to the next slide. Today's intersection of prevention and recovery is a collaborative webinar series brought to you by the Peer Recovery Center of Excellence, the Great Lakes Prevention Technology Transfer Center, and the Prevention Technology Transfer Center Network. Funding for this initiative was made possible through a SAMHSA grant. The views expressed within this webinar and the materials are solely those of the presenters and not necessarily the views of SAMHSA. Thank you. The Peer Recovery Center of Excellence focuses on 4 core areas. So we have a team that focuses on clinical integration, one that of peer recovery supports. We have another team that focuses on strengthening and building the capacity of recovery community organizations. Our third team works on helping to develop and support the development of the peer recovery workforce. And then our fourth team focuses on providing evidence-based toolkits and resource information to diverse stakeholders. And of course, language matters. So if we want addiction to be stigmatized, we need language that's unified. So in all of our practices and presentations, we're always sure to use person-first language and not describe someone as their disease or their diagnosis.
Whoops, sorry about that.
No worries. So here's where I'm going to hand it over to Carol. Thank you.
All right. So people have already started doing this. So if you're just on, you can feel free to put your name and where you live. And people have been putting in the weather. And we've got everything. I think the highest temperature I've seen is like 115. So we also have people from Singapore, I believe, on, and Indonesia. So we've got a variety of different people from not just the United States, but across the world. My name is Carol Oliver, and I'm thrilled to be here. And I have been working in the substance misuse prevention field since the 1990s. And for about 15 years, I oversaw prevention services in a full continuum treatment organization agency. And I spent a lot of time in that time sort of trying to figure out the connections between prevention, treatment, and recovery. Several years ago, I had the opportunity to work with a group of professionals thinking through the relationship between prevention and recovery. And I have to say, of any of my professional experiences, it was one of the best, and I learned so much. And so when this opportunity came up, I was thrilled to be here and to work with my colleague, Hanir Hernandez, who's amazing. And I'm going to turn it over to you, Hanir, to introduce yourself.
Thank you, Carol, and my apologies, technical difficulties from my end. The internet is acting up today, among other things. And good morning or good afternoon, depending on what part of the world you're in today or right now. I am Hanir Hernandez, and I've worked in the field of health and human services with a very specific focus on addressing issues of disparities and building equity. I am originally from Puerto Rico, and I live in Massachusetts. I work across the continuum. I work in prevention, intervention, treatment, and recovery supports. I've worked in residential settings, outpatient settings, but for the most part, not-for-profit settings doing this type of work. I get to travel the country in the US. I've worked in every single state except the state of Alaska doing this type of work. I have a lot of initials after my name, as you saw from that initial slide. I have a PhD, but I also have a GED that I got in prison. I'm a person in long-term recovery, and what that means for me is that I haven't used a drug, including alcohol, for the last 34 and a half years. Someone gave me an opportunity, fresh out of treatment, to make a contribution, and I have been learning about this work ever since. And so I look forward to our conversations today and to hearing from you. And we have an exciting, couple of hours to share information with you and to hear from you. So thank you very much. Someone just put in the chat about closed captioning. I don't see it at the bottom of the screen.
Let me check with Callan and we'll see if we can't figure that out. And here we go. If you see right now, I believe if you click at the top of your screen, you should have a pop-up box that says live transcription closed captioning has been enabled. And I believe if you click on that, I'm going to do it with you. I'm not sure how to turn that on. Do you know, Callan, how to turn on that function individually? Oh, someone says they see the CC.
Yeah, there should be a CC button. It'll notify you at the top that it's been turned on. And then if you want to turn it on your individual, on your own screen at the bottom, if you, there's like the green share button to the right of that. There's a CC button and you can click that to either view the subtitles or you can hide them if you don't want to see them.
Perfect. We have such a wise audience too. So they're all
Yes,
catching on
we do.
just as quick as we are. All right. I'll turn it back over to you.
So Haner, do you want to take us through the guidelines?
Yes, yes. And for those of you who were with us during the previous session, thank you very much. You can recall that we asked you some questions about guidelines and provided some of our own. And so you see them there that we have agreed to participate respectfully, to come to this endeavor with an open mind, to share the message and not the messenger, right, to issues of confidentiality, that we practice the stretch rule. If you're one of those people who tends to participate a lot or talk a lot, to stretch in the other direction. And if you're one of those people who holds back, to take a chance to say something, because that very something can help other people out in this process. That we should assume that people come to this with good intentions, right? As we approach our work with good intentions, people come to these conversations in the same way. And let's agree to be strength-based, right? You know, there's the field of substance misuse or substance use disorders has been riddled with a lot of putting people down. And what we need to do is elevate people up, elevate issues up that are important to all of us. So let's continue in that vein of being strength-based. If there's anything that you would like to see us add to the sort of working agreements, please put them in the chat. More than happy to look at those. Can you jump to the next slide, please?
Yeah.
There's some general tips here in terms of coming ready to participate fully and critically in online learning, right? And to do your best and engage with the technology. We have been into this COVID piece for over a year now, and we know that COVID fatigue has kicked in for many people. It's tiring, you know, that sort of thing. Thankfully, today we're meeting in the morning on a Tuesday, right? It's not the afternoon on a Friday, which is more challenging for people. Next slide. In terms of chat etiquette, and we know that, you know, people, you have experience doing this, but we just want to make sure that we mention it out loud, that you ask questions, that you keep private conversations to a minimum to avoid distractions, right? That we are respectful, back to those sort of working agreements, that we're professional over chat. And if you wouldn't say something to someone who's standing right in front of you, don't do that in the chat, right? We shouldn't do that. And we've seen over the last year and a half, a lot of people say, well, you know, I'm anonymous here, or I can, you know, I can say some things that I wouldn't say to people in front of them. That doesn't work well in terms of engaging with people in critical thought, critical conversations, those sorts of things. So thank you for agreeing to participate in that way. I think that that is our last slide, right? In the section, yeah.
Yeah, so thanks so much. And so for some of you, you have been, you were at the last session that we had, and the participants just had the most great conversations and really made the training incredibly interesting. And so if you haven't, if this is the first time that you're here, welcome. I think that we're going to do some review. And I think you'll get a lot out of today as well. But what we wanted to do is to sort of start with and reflect back on, for those of you who were at the first session, something that you learned the last session, any kind of aha moments that you had in the last session that you want to share with the group. So something that you learned, an aha, something you weren't aware of, something that surprised you. So anybody who was on the call want to share anything in the chat? And we have, I think, some common languages and goals between how prevention and recovery services are less collaborative. I now work union, yep. The barriers that still exist with perceived equity. Excellent. Loved hearing from Hanair. Provide strength-based voice. Appreciate the open discussion. I had an aha moment. We were talking about language and the fact there is similar language used in prevention and recovery. Excellent. Recovery is behavior change.
You see here the types of recovery capital.
Yep. Excellent. And Hanair, not to put you on the spot, but did you have any ahas having been the presenter?
You know, not as much ahas, but really, really good to hear all of the conversation in the chat with people respectfully challenging each other in concepts, and quite frankly, challenging us in terms of what we say, those sorts of things. And for me, it's always good to hear that because I learned that education is supposed to raise questions. It's not a passive experience where you take things in and you accept everything that comes your way. We are supposed to be critical thinkers. And so it pleases me a great deal that when, that we were engaged in that conversation, that people were, questioning and saying, this is my view on it. This is how I do it. This is how I think about it. This is my experience on the ground. This is my lived experience with this. And all of that is really powerful to see because of what I just said in terms of how I view education. But the other piece is our field is growing and is attempting and doing a really good job at bringing down silos. And so bringing down silos, addressing equity, addressing issues of discrimination and stigma require difficult conversations and require that we share respectfully what we're thinking, and we don't always think the same. So for me, that was really powerful in the chat. Carol and I wish we could have done this in person, right?
Yeah,
That's a different
exactly.
Right.
It was very gratifying though. It's one thing to know something theoretically, like theoretically, when you break down silos, right? People need to challenge and talk through and whatever. It's one thing to know that sort of, theoretically. It's another to see it in the moment happening right in front of you in a virtual setting. And so that I found incredibly exciting because that is how, in the moment, we were seeing role modeled how silos are broken down, that people own their part of the perspective and ask and challenge and do all of that in a polite way. And that's how people sort of learn and understand and sort of find the differences and the commonalities. So I found that incredibly, incredibly gratifying. And that's why it was all of you. So that's great.
To that point, Renetta says how prevention and recovery services are less collaborative due to their position on the health promotion spectrum, right? And so those are the things that we're trying to address. And we talked about the multiple pathways of recovery and the fact that we should put a menu of options for people in front of them. And Cora talks about that in the chat in terms of being more like a restaurant. And then again, with some more lived experience. And so all of those things are really awesome that you're thinking about them, that we were able to raise those issues with you during the previous session.
That's fantastic. So what we want to do now is just do a quick, for anybody who wasn't here the last time, we just are going to do a couple of slides just to do review, to have it fresh in people's minds. So one of the things we talked about was this continuum of care. And what we really use it for is to sort of understand, you'll see prevention on the left-hand side. And one of the things you'll notice is that it has 3 categories under it: universal, selected, and indicated. And so what we find, oops, sorry, I'm just having a clicking problem. 1 second. There we go. At the bottom with promotion, there's wellness. And that was a real theme that came out the last time, that wellness is sort of built into prevention, treatment, and recovery. And so that's a really important piece. The other thing is that when we're thinking about where prevention is focused, and this actually came up in the chat last time, is sort of, what's your definition of prevention? And so the way that we're defining prevention is sort of, it occurs before the onset of a problem, right? Before somebody may be misusing substances. But it also occurs before a diagnosis, or, and what I want to do is change this, is before a diagnosis or before somebody decides for themselves that they want to be in recovery. Because as we found the last time, about 70% of people who decide that they want to be in recovery have never entered a treatment facility. So if we just say before diagnosis, it makes it sound like everyone is going to treatment. And we know from experience that's not the case. So prevention is really going from the before the onset and before the diagnosis, or before somebody chooses to go into recovery. And that's sort of how we're defining prevention. Now, people will work in different parts of this, right? Some people may work more on the before the onset of the problem, and some people may work before diagnosis or somebody decides to have recovery. And then some people may work across all 3 of those, but we take a broad definition of prevention when we were doing this presentation. And that kind of brings us to, oh, and the other thing, and this came up a lot, was this idea of changing conditions. So one of the things I do love about prevention is that underlying what's going on is this emphasis on the fact that the environment is important, right? There's this old analogy that fight a frog and it was in a pond and the frog started getting sick. Would I start blaming the frog because it was ill? No, I would try to find out what is in the pond that is making the frog ill. And I would be looking at the conditions, and I'd need to know that I need to change some of the conditions. So that's sort of what we did, is revisited the definition of prevention. And then the definitions that we have, and I'll go through these really quickly. One was universal, which means the whole population, right? It's like every 9th grader or the entire community gets a social media message. Or a commercial you'll see. And so those are sort of public policy, media campaigns, prevention level curriculum. So this is sort of your universal, and this is before diagnosis. Then you have the selective, which is really targeting people who may be at more at risk. So if my family has a history of substance misuse, or I have a family member who's actively using in my family, that's going to put me more at risk. And so there are interventions that are specifically for sort of early intervention and education and having that target population. A good example is sometimes young people are arrested for nonviolent court cases, right? And so one of the things they often do is they have them include some alcohol and other drug education as part of what they end up doing, because they're considered a more at-risk population. And then lastly, whoops, is this indicated, sorry, 1 second, population, which means people who are currently maybe misusing substances. So it could be someone who is misusing their prescription drugs. It could be somebody who is using alcohol or other drugs to self-medicate. But they are not currently in recovery, and or before they've had a diagnosis. And this is the population that's really shared across prevention and recovery, is the indicated population. The other population that's really shared, that's connected to, is the selective population. So if my mother or father in recovery, which is fantastic, then what that means is that because there is a family history of substance misuse, I may be more at risk. So working with kids whose parents are in recovery or parents who are actively using is working with kids who may be more at risk than just the general population. And so there's a linkage there. There's this intergenerational substance misuse that we want to interrupt that pattern. And so selective is also something that can be shared across prevention and recovery as well. So any questions on that so far? And I haven't looked in the chat. All right, I'm not seeing any. So let's see. So prevention goes all the way up to before some decides to enter treatment recovery. That still involves diagnosis. I think this is important because are not involved in diagnosis. The whole area of identification of screening and referral is usually at least often done by treatment professionals. Yes, so this is really interesting. So yes, so indicated means that the person is currently using or misusing a substance, and it is before they get a diagnosis or before they choose to be in recovery. Exactly. And once somebody gets a diagnosis, they're considered in treatment. And once they decide in reference to being in recovery, but it's not so black and white, right? I mean, I could be in recovery and I could relapse, right? And so I'm an indicated population again, right? But I'm also in recovery. So it's not so cut and dry. We're sort of talking about people. And I could have somebody who's in treatment and then that person leaves treatment and they relapse. And now they're in reference to an indicated population. And so that's why when it comes to the definitions, I think it's helpful to be aware. I think, but we have to be really careful about, I don't want to say pigeonholing people. Now, what works against us or what makes it a little difficult is the funding. So when you're saying, you know, prevention doesn't do early intervention and referral, that's very much, and having been a preventionist for a long time, the way the funding goes is it's thou shall not do an intervention and give somebody a diagnosis because that is not part of your realm. And that's true, right? That is part of the other realm. But when we're talking about the indicated population, it's why communication between recovery and treatment and prevention is so important, because what happens to that person who was in a treatment program, and let's say they're now in residential, and for whatever reason, they end up having to leave the program, and now they are using again. Who's going to take care of that person, right? But if the people in treatment know the people who are working in reference to the indicated population, and everyone is talking, the likelihood that that person is going to get support and help is much greater, right? So I think it's about giving people the maximum amount of access to resources and to sort of pathways that can assist them. And that's a way of looking at it. It's the pathways. And I see Hiner shaking his head, and I want to make sure that he gets to be in here.
I wanna thank you for the observation and the question there, because it makes us think, right? And so I think on the ground, right? Regardless of these categories where people fit, that sort of thing, we love categories, putting people into categories. The way things happen at community level, they happen in many different ways. The communities that I work with, people don't go to professionals first. They might go see a spiritual healer, they might see a pastor, they might see a priest, they might see a grandma, they might see someone. They will see people on the ground that they go to first, even before coming to professionals. And some people don't even make it to coming to see a professional. And some people who have stopped using substances and don't identify as being in recovery stop using substances. So even those categories of imposing that over people become somewhat problematic. Remember the conversation on the multiple pathways of recovery, and that some people use a faith-based pathway and they don't consider themselves to be in recovery because they've been delivered, or God lifted the obsession to use, and so they no longer do that. They have never been anywhere where they have been diagnosed. They have never been anywhere where they've been told, right? Now they come in contact with people who talk about going to meetings and that sort of thing, but they don't participate in that. And so this requires that we stretch our brain and say, wait a minute, the categories that we have that are these neatly defined clinical categories, many times they don't fit for a lot of people. And a lot of people will not have a diagnosis in front of them. And even if they did or do, some people reject those and say, you know, that's not me. That's your way of viewing me. Crazy Like Us, really good book on mental health diagnosis and the history of the DSM and diagnosing people. And so I recommend that people read that because it's a well-researched book. Again, Crazy Like Us, and it's all about cultural aspects around issues of diagnosing people. And so we should always think outside of the box, right? Always. And that doesn't mean that you need to agree with it, right? Because I believe in the disease model of addiction, but other people don't. And again, who am I to impose that over their beliefs, right? So you make me think about that.
That's great.
Mhm.
That's great. I think that's very well said. And and I think we live in, when we receive public dollars, we live in two different worlds. We live in two different worlds, or many worlds. But one is the world where we recognize that funding is allocated by, the legislature, and there are parameters around it, and then it goes in certain buckets, and that's how kind of the system works. And when you get money from you get money, you have to say, I'm taking it in this bucket, and this is what this bucket pays for, right? And that's what you talk to your funder about. But knowing when you're engaging with people, like, so if somebody overdosed and they needed naloxone, we wouldn't say, are you in recovery? Are you in treatment? Or we wouldn't ask those questions. All we know is that somebody needs help at the moment right now. And so I just kind of want to re-emphasize what you're saying, but also recognize the reality of is we do live in a world where funding has constraints, and you can get funding for some things, but you can't get funding for others, and that's real. So that's great.
Carol, I wanted to say this. A couple of people have asked us both to turn up our volumes. Mine is
Oh, sure.
all the way up, and I have a headset on. So my apologies, but we are checking into that. But thank you.
So
for,
let me do
for
one.
letting us know.
I just need to do one thing in order to do that. I just need to get out of this presentation for one.
No, Carol, you're just fine. It's just Hanir's volume that's a little bit lower.
Okay, great.
So you're coming loud and clear. And then Hanir's just a little quieter. On my end, I can hear Hanir just fine, but we've just had a couple people comment he's a little bit quieter, but I think, yeah.
All right. So the other thing too about the indicated, and remember it's before diagnosis, and what you're trying to do is sort of reduce the risk of people developing a problem. And then when you're talking indicated, you're trying to reduce the amount of harm somebody's going to experience. And so there's sort of that reduction of harm, and prevention is doing both pieces. So towards that, the other thing that we find is that there's the concept of risk and protective factors, which many people are really familiar with. So risk factors increase the risk. Some of them are biological, which may mean that substance misuse disorders run in my family, so I have a more increased risk. It could be I also are friends with kids who are also using substances, which would increase my risk. And then we have some family related risk factors. So within that, so if my family does not really set limits or have ground rules, or there's no bonding within my family, there's family related risk factors. And then there's the community. There's a lot of social isolation. If there is less connectedness to the community, if I have a liquor store in every single, corner, and billboards everywhere, and the environment is really telling me to use substances, then that is also going to be a factor that puts me at risk. And then we have the other, which is we have the factors that protect one as well. And so that would be in the family, that would be creating social bonds or healthy adult role models that people have healthy connections to. And what you find around the protective factors, which is really interesting, is a lot of them are connected to this idea of bonding and building relationships and connection. And what we find is we have them in each of this on all three levels. And so what preventionists do is they look at the mix of risk and protective factors within a community, right, or a population, and they decide on the ones that should be reduced and the ones that should be increased, with the hope that this will then mitigate somebody's likelihood of developing a problem. And so that's sort of what we call the risk and protective factor framework. And what's interesting about it is it's hard to believe because it's been around for so long. But when I started in the field, it was just beginning. And normally what people went to is, here's the problem, here's the strategy. And people used to write grants and saying, I have a mentoring program and I think it will do this. And there was no connection to, well, what's the lever? If a risk and protective factor is a lever, what's the lever that program is changing that's going to impact the problem? And so, you know, the prevention field is a young field. And so I think the risk and protective factor framework has really assisted the field in really being able to push those levers of risk and protection. So before I turn it over to you, Haner, anything else you want to add in reference to this as we just sort of quickly review?
Someone asked in the chat the question that they don't diagnose people, so that they would like to hear more, where they would learn about sort of where treatment services are, that sort of thing. And I would say to people, look at your state funding source primarily to look at where services are located, that sort of thing. At another level, look at those at the county level, if you have access to that, and at the local level, at the city level. And I would encourage you to look for coalitions and groups that meet periodically to talk about what's available. I would look at sources like the United Way and other spaces and places that usually publish lists of information where resources are at the community level, and networking, right? Because services are forever changing. Some things are added, some things go away, depending on what those things are. And always, 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 always think outside of the box in terms of looking for services, particularly for marginalized populations, right? Make sure that you have a robust list of spaces and places where people are accepted and are treated with dignity and respect.
That's fantastic. The other thing that most states have is they have a substance misuse helpline that both is a line that you can call and you'll talk to a real, you know, a live person 24 hours a day. And they will ask you a series of questions about finding services. And there's also that online component. And most states also have what they call a 211 line as well, which is sort of like 411, but it's for all social services. So sometimes there's an ancillary, there's another kind of need that in order to have somebody find treatment, they need a different kind of service. And so that social service network is sort of, those are two really good resources as well. Yeah.
And don't forget your local, your recovery community organization. So those
Yeah.
were created to fill that gap. And between, you know, prevention and treatment, your recovery community organizations are usually the most low threshold, no barrier intervention that you can offer someone.
Fantastic.
I'm smiling because how could we have forgotten about those?
Yeah.
You're right. You're right. Thank you for that, Chris. You're right.
Well, the other thing, and we're going to get into the roles in a little while, but I have to say one of the things, and I feel passionate about this, is when you're doing prevention work, oftentimes people will see you as a resource and they want to know information about how does treatment work and what do I do? And I'm worried. And I often, not nearly probably as much as Haner, but I get calls several times a year from just people who know me, family, friends, or whatever, just wanting to figure out how do I navigate this. And so I think that preventionists really can be an ambassador to help people be able to help navigate and find things as well. So I'm going to turn it over to you.
Yes,
sure.
I would say this because I'm seeing some important stuff in the chat, and you know, people want to go there. People asked about what to do, right? So in the previous session, we talked about collaborations and what those look like, right? I am a strong believer of getting outside of the office, right? Meeting with people where they're at, meeting with organizations. And we are strong believers of formal collaborations with MOUs and MOAs. In other words, you're going to do this, we're going to do this as way of collaborating. Most collaborations happen, you know, a relationship that I have with Carol. And if Carol leaves that organization, there goes my relationship with that organization because she is no longer there, or vice versa, right? And so formal collaborations are really important to have. And then someone asked, how do you locate recovery communities? Do you mean AA, Alcoholics Anonymous? Those are resources that are online, and there's 1-800 numbers, those sorts of things. Come to the Peer Recovery Center of Excellence, and you will see connections there to the recovery community and to recovery resources. So come to our webpage. I'm on the steering committee, so I want to put in a plug for that. Also go to Faces and Voices of Recovery, national organization. And you will see that there at that webpage, you will see connections to the state recovery organizations, right? So you can look at them, and we should look at them from the national level to the federal level to the local level, because there's many organizations that are identified as recovery organizations that are at the local level, and they might not have all of these fancy web pages, that sort of thing, which then again requires that we get out of our comfort zone, out of our offices, and into communities, right? Chris just put up the link to the Peer Recovery Center of Excellence at the national level. And other people throughout the chat are talking about, this is what North Carolina does, this is what my state does, these are the coalitions, those sorts of things. But I would be remiss if I don't mention this. If you don't have those organizations on the ground, know that there are people who are interested in developing them. There's an opportunity for collaboration, for connection, those sorts of things, because we know we're speaking to a national audience. This is urban, suburban, rural, frontier, and some spaces and places don't have this stuff. So we appreciate the question because of that. So hopefully that helps. And again, monitor the chat. There's people even putting up 1-800 numbers. I'm just looking at the one for Virginia. So go ahead and look at those. Thank you very much. So to recap some of the stuff that we talked about last week as it relates to recovery, and we've already begun doing that, right? We gave you this definition of recovery that comes to us by way of SAMHSA, the Substance Abuse and Mental Health Services Administration, who really should change their name from that substance abuse stuff, right? We're talking about being strength-based, but it's a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. We know the 4 domains that we talked about: health, right? Overcoming and managing one's diseases, physical, emotional health, those sorts of things, and wellness. We know that a huge part of the next domain is in the area of having a recovery conducive place to live, home, right? And that doesn't mean that people who don't have a home can't access and sustain recovery. We're just talking about that it makes it more difficult, right? So our push is to create more places and spaces where people live that are recovery conducive. And then purpose, right? That's that thing that we all come to every day to work with, right? It gives us a sense of direction, a sense of accomplishment, right? This field doesn't pay a lot of money. And so we have purpose. And the people seeking or in recovery, they are also seeking some level of purpose. And we usually hear it, particularly from the recovery community, in terms of when people say, I want to give back, right? That means I want to make a contribution, because making a contribution helps support my recovery. And in turn, I get to help other people. And there's a lot of reciprocity in that. You do it we do it by way of volunteering, by way of work, by way of relationships, but in many different ways, right? Relationship with faith and spirituality for some people. For other people, it's defined in a different way. We should always look for opportunities to help people develop a sense of purpose. And then community. I said last week, I belong to many different communities, right? To the recovery community in general, to the Puerto Rican recovery community where I live, to the Latino recovery community in my state, to a professional community, to an artist community, to many different communities that help me sustain and develop purpose. More importantly, it helps me, and it helps millions of people all over the US to sustain recovery, because recovery is about relationships, right? And our work is about relationships. The more that we can do that, the better off we are. in terms of supporting people. So that to this definition of recovery. And we also encourage you to go to williamwhitepapers.com. And William White is a leading researcher on all things recovery. And you can look at his, YouTube pieces. We also talked about the fact that in October, the Multiple Pathways of Recovery Conference is happening in Florida, and that we encourage you to go there. And William White, in addition to many, many other things, in his definition of recovery, he says to us, different from treatment, and I'm paraphrasing here, different from treatment that has been both defined and is done by professionals. Recovery is defined and done by the individual. And we have taken that a step further in Recovery Coach Academy and training recovery coaches to say what? People are in recovery when they say they are. And many people from the professional world have difficulty with that because they want to tell people, you're in recovery when you stop using. You're not in recovery when you're doing this, or you're not in recovery from doing that. And it's an attempt to be strength-based and to give power to people, redress power imbalances, and allow people to identify the way that they want to identify in the pathway of their choosing, right? There are principles of recovery management that we talked about as well. And so an emphasis on resiliency and recovery processes. Again, with the multiple long-term and short-term processes of recovery, right? And this emphasis on being strength-based. Our folk who have experienced homelessness, who have experienced mass incarceration, who have experienced trauma in very significant ways, they don't come to us broken, who need saving. They come to us with a lot of knowledge, resiliency, and strengths. And we need to be able to pick those out and help people develop those further, as opposed to saying, you're starting from zero and I am the person to save you. That is a deficit-based approach that has not worked. That we should be about allowing people to take power for themselves, including families, and understanding that substance misuse or substance use disorders or addiction, however it is that you want to define that, is not an issue that only affects the individual. We need to couch that in families, in communities, and society, right? Understanding that. And that our services need to be couched in cultural humility and cultural intelligence. People come to us from very diverse pathways, right? In terms of their own lives, like all of us in this room come from really diverse and similar cultural backgrounds. And so our programs need to be responsive to those. And we need a heightened awareness of what collaboration means. And we need to couch that in social justice, I believe. And we need to couch that in how we engage in collaborations that are meaningful, that address disparities and build equity and do those sorts of things. And we need to be committed to best practices, evidence-based models, promising practices, all of those things, right? Because for some communities, we don't have the best evidence-based practices, but it doesn't mean that we don't have best practices or promising practices, or that we cannot engage with those communities to develop evidence-based models that respond to what their reality is on the ground, right? So when we think about recovery management and the principles contained here, those are some of the things that we encourage people to think about. We have one more slide. And so we did a lot of talking, and some of you came into the chat talking about what you learned about Recovery Capital last week, right? And so again, William White Papers and others have written a great deal about Recovery Capital. That's the internal and external, right? Recovery capital that people possess and develop internally, right? I have a roadmap to what has worked for me and what hasn't worked for me in the past. That's an example of internal, right? Recovery capital. I know that I've been to this detox, or I've been to this treatment facility. I know that I can go here for this service, that service, right? Examples of external recovery capital. Resiliency, internal, right? My ability to say no, or to say yes, or to ask for help. Those are examples of internal recovery capital. My relationship with the recovery community and individuals within that recovery community, examples of recovery capital. The reality that I have a sponsor or a mentor or people in my life that understand this piece that I identify as being in recovery, right? Those sorts of things are part of recovery capital. And we should, recovery capital, as we mentioned before, connected to risk and protective factors, right? Because the more recovery capital you have, right, the more we are increasing people's protective factors. The less recovery capital people have, those become risk factors, right? So there's the connection to prevention, or a connection to prevention. And then finally, I'll say this. Recovery capital is also connected to ROSCs, recovery-oriented systems of care. When those exist in the community and they are put forth in a way that they're interconnected, and that when people go to access services or go anywhere, when there's a strong ROSC, that contributes to huge recovery capital, not just for individuals, but for families, for communities, for entire cities, towns, areas, and states, right? And so we're moving in that direction more and more and more. And I am really happy that we're paying attention to this piece on recovery capital. So that's a little bit of what we talked about last week, right? And I want to thank people in the chat talking about, ROSCs and everything else that you're mentioning, chiming in and really reinforcing the fact that these are the ways to go. Now, if you're sitting here and you're saying, I only wish, Janet and Carol, those sounds really good, but in my community, those do not exist. There are supports at the national level, at the state level, and at the local level. And remember, some of this stuff didn't exist at all in the communities that they're in now. So we have to start from somewhere. You're not alone. Reach out. There are services and supports to help people figure this stuff out on the ground. Go ahead, Carol.
Excellent. And you definitely got a shout out around, instead of thinking that the person needs or is seeking service, to think of them as a solution themselves, which I think is really powerful. So that's great. So we're going to go a little deeper. So, the last time what we did is we really looked at prevention and then recovery and made sure everybody sort of was on the same page about some fundamentals. Now we kind of want to look at them in relationship to each other, and how they're similar and how they're different. And this will hopefully take us down a path where collectively we're exploring where are those ways that we can collaborate and work together. And just like learning about prevention and recovery, it's not a straight path or a straight line. And I'm sure we're going to get a lot of interesting conversation as we explore this together. So, I think that we're providing sort of the canvas to do this, but in exploring prevention and recovery, it sort of takes all of us. There's no one who has that answer about how to go about doing it, which I kind of like. I like working on things that there's not a set answer and we all kind of collectively have to figure it out together. Okay, so distinguishing prevention from recovery. So this is really what we would call upstream. So think of the universal and selective, because as we said, indicated really connects to the recovery population. The recovery services also works with indicated population, but it comes prior to the diagnosis or somebody deciding that they think of themselves in recovery. And the interventions are to reduce the risk. We talked about this, and enhance protection. And there are actually a couple of different kinds of strategies. So there's education, in which you can get education in the schools and curriculum. There can be parenting education. There can be community-wide education, policy. I think the easiest policies to kind of reflect on is before we had tobacco policy, and you could think about people reducing tobacco, it was really hard to do just using education. And it was really the policies that were put into place that made a big impact in reference to that. Enforcing existing laws. So laws are as good as they are to be enforced. So whether that's sort of drinking and driving, and whether that's, kids getting access to substances. Now, that being said, I also want to make this point. There has been injustice in our, judicial system and other systems. And so when we're talking about enforcement, we're talking about a prevention strategy, but that strategy, depending on what's going on and where you live is going to seem and look different. And I think we have to put that out there, right? I mean, enforcement is something we should be working on, but not everybody experiences it in the same way. And the system is not fair to all people in the same way. So I want to make sure that that's said. Communication and public education. So communication campaigns that you'll see. There was a community I worked with, and they had this campaign called The Power of No, KNOW. And it was just raising people's awareness about what the problem is. A lot of times you'll see the United States Advertising Council will do commercials on different kinds of prevention related. You see a lot of parents talking to their kids. And then again, it goes back to relationship building and bonding. And, you know, at the heart of it, whether it's an individual bonding or an individual bonding to a system, it's this relationship building that is so key and so important. So those are things that distinguish prevention. And then we have distinguishing recovery from prevention. So these are how they're slightly different. So the services begin as committed to his or her recovery. And Haner, you can tell me if that's true or not. Is that a true statement?
Yes.
Yes. Okay. And recovery supports include all services that support individuals. So we're talking childcare, employment, housing, peer coaching. So imagine anything that gives me a healthy, well life, right? Which is my spirituality and my financial health and my physical health. All of those things goes into peer support, sober social activities, life and parenting skills, and advocacy, again, for policy that supports, you know, health, recovery and health. And a lot of parts about, you know, the recovery community being separate from what's going on in prevention is we're all kind of living in one community, right? And that includes people who are in recovery within the recovery world, and that includes prevention people as well. So it's not like we're talking about two worlds. So that sort of distinguishes recovery and prevention. Haner, is there anything you want to add to this?
Yeah, going back to that first bullet point, support services begin when the person has committed to his or her recovery. There are services, I want to take that back a little bit, because there are services that begin even when the person hasn't committed to it. Let's not forget, many of the people who come to places and spaces to request services are actually there because they're coerced. And that's a huge chunk of people because of what the criminal injustice system, and I'll say it that way, has done through mass incarceration. So a lot of people come to us. We have the largest prison population per capita in the world, 2.3 million people, right? And 5 to 6 million people on probation, house arrest, or parole. And a lot of those people are coerced into care, and which means that many are in pre-contemplation or contemplation. They're not in this preparation or action phase, even if they're sitting in treatment facilities or in centers and shaking their head up and down. Is like, nope, I'm here because this happened to me. I was sent here, or I was caught, those sorts of things. And so many times you're not committed, right? People committed to recovery fully, right? Because that's not what they're there for. But the services are helping them in different ways. I myself personally went from prison to treatment, not because I wanted to. So I sat there saying, my mistake is that I got caught. I don't have a problem. These people have a problem, but not me. Internal voice, Haner, right? Clearly in pre-contemplation, but the services were still there. And the people who were providing services were still engaging with me and helped me to go from pre-contemplation to contemplation to preparation to action, right? Another training for another day, stages of change. But just know that for some people, these services begin, the services can begin way before they're committed to anything.
That's excellent. That's excellent. And for the preventionists on the line, one of the things is you were talking about pre-contemplation, contemplation, and readiness to change. Within the prevention field, there's also this idea of readiness to change for communities, right? Is my community ready to change? Is it in denial? Do I have people who are willing? Do they see it as an issue? And oftentimes when we're trying to explain community readiness, we start with individual readiness because people can relate to it. So that's just kind of interesting. Okay. So now it's your turn. So what's your experience working in, so the first question we're going to ask is, what's your experience working in prevention? So if you're a prevention person, or if you're in prevention and recovery, you could, go in both polls, that's fine. The first poll is going to be, if you work in prevention, just put a check on the kinds of work that you're doing. So you'll see this matches what we had in this slide. Education, policy enforcement, communication. And then we have the same question if you work in recovery. What are the things that you do? Childcare, employment, peer coaching. And we're going to bring up both of these slides. We're going to bring up a poll, and we're going to have you all tell us kind of where your work is focused in prevention and in recovery. So I'm going to turn it over.
Carol, the poll function is not available. So if people could answer in the chat, that would be great.
Oh, that's great. Okay, that's my bad. So I apologize. Yeah, so feel free to answer in the chat. So we've got some people do both. Education-based programs. Yep.
While people are typing in the chat too,
Peer coaching.
someone asked a follow-up question to Hanir. Do you think that diversion and reentry programs are effective? I don't know if you want to answer that while people are typing.
That's a really good question. I think that this is a big ship that we're turning, and we're not quite there yet. And so we have a whole bunch of things across the country. So for example, here in Massachusetts, in a small town called Gloucester, the chief of police said, we're not arresting our way out of this problem. So what we're doing is we're running a background check on people. If they show up at our police station, we're bringing them to treatment. If they come with small amounts of drugs, we're not going to charge them with that. We're going to take them to treatment. That was revolutionary. Everyone in the law enforcement community across the country went sideways. Like, wow, you're condoning, you can't do that. We're law enforcement, we're not social workers, we're not here to coddle people, all that stuff. Since then, the model has been replicated in over 38 states. How's that?
That's amazing.
We have recovery coaches embedded with police officers. We have police officers who don't have identifying, things that they're wearing, not even guns. I have police officer friends who are in recovery, who are working in these programs, and they are responding and visiting people in their homes after they overdose, connection to prevention, all of that stuff, community collaboration. And all of that is working really. We also have drug courts, veterans courts, mental health courts, all of those things. However, we are not where we need to be, but those are really good advancements, right? And so we cannot throw out the baby with the bathwater. I said it in some spaces and places. A lot of those programs need a lot of help, but we need to start somewhere. And so this piece on incarcerating people hasn't worked. And primarily people of color, marginalized communities, that's what we got. 80s, 70s, 90s, and still that's what we're getting today because we're not fully there yet. That's the social justice piece coming into the picture, right? And so we have a responsibility to engage with those systems and to help those systems think about how they do things differently. So for example, in the state where I live, Massachusetts, progressive state, right? The majority of people who go to drug courts are white, upwards of 80%. Why is that? We come in with a lens of social justice and an equity lens, and we say, wait a minute, it's not because people of color are more violent or more criminal. It is a systemic piece. So we need to address issues of institutionalized racism within this entire system and look inward into ourselves and into this process. So I think that they have the potential of working, and some of them do really work well, but we can't paint with a broad brush and say they all do, because it's to varying degrees. My best answer at that really, really powerful question. Thank you for that.
That's great, Hanir.
Mm-hmm.
That's great.
Mm-hmm.
So it seems like people have an experience with all of these, right? And there's some people who are shouting out about the drug court. So on the prevention side, we have people who do the sort of coalition building and the education programs and the policy. And then on the recovery side, we have peer coaches and advocacy came up a lot, peer coaching and support. So a lot of what you see on the screen is what you all are doing. So what we want to move to now, whoops. Okay. So here's another question for you. So, we've seen you both, and some people actually have worked in both prevention and recovery. So from what you've seen and heard so far, either from the first one, what do they have in common? What do prevention and recovery have in common? What are those commonalities that they have that you can see between prevention and recovery? Anything that you see? Orientation towards wellness. Yeah. It's about wellness, promoting wellness. Yep. A lot of people both want healing. Yes. Self-directed. Path to living involves community. That's another. Relationship building is key. And wellness. Harm reduction is a part of both. Quality of life, wellness goals, learning, social emotional wellness and stability. Empowerment, policy, coalition, focus on strengths. That's true too. Resilience is mentioned. Harm reduction, awareness, commitment to cultural competency or cultural humility. And Haner talked a bit about that. The program I know are Angels and Perry. Building humans. I love that. The whole life. Community. Excellent. Skill building, wellness, harm reduction, safety, security, respect, compassion, and empowering. Yes. Okay, so those are fantastic. So, and some of these you mentioned, right? So when we're thinking about things that have in common, and you guys hit it, wellness. Wellness is the goal of both prevention and it's the goal of recovery. It's having both a well person as well as a well family and a well community. It's all of those things. This idea of increasing protection and reducing risk, which is in the recovery, it's increasing recovery capital and reducing the risks. And then it's community involvement. You need community involvement in both. And I think that's what I was struck by Haner when you said, Haner, about, if you don't have this stuff now, it doesn't mean you can't develop it because the other people who have it didn't have it to begin with anyway. And they had to build it. And there's an advocacy piece that is built into that, I think. And you're also talking, in inviting a preventionist into your desire to make community change is a really good thing because they're used to, how do you do that? What are the tactics that you use? How do you educate? Community change is what they're sort of all about. So you're working with somebody who understands what's involved in that. So some of the other similarities. So one is variable funding structures. So in both prevention and recovery, I've seen prevention funding come from the federal government, the state. It also can come from towns. It can come from private foundations. It can come from a variety of different sources. It can also come from organizations. I've seen different nonprofits pool their resources in order to do prevention programs in the summer. And it didn't come from outside funding. It came from sort of funding that they themselves had that they wanted to spend. And I think the same thing is recovery. Recovery comes from different funding sources. I saw a district attorney's office in Middlesex, I think it was one of the counties, and they had recovery support coaches as part of what their outreach was. Various settings, right? You're not sitting in the same place doing either recovery or prevention. You are out, you are talking to people, you are building relationships. And so it's not just occurring in one place. Volunteer supporting. So recovery has a lot of volunteer support, and though so too does prevention. You can't really build prevention approaches without having the community present. And often part of the community participating is volunteering their efforts, their time, their talent. And then you're also focusing on both the individual and the community at the same time. And so that's something else they have in common. At times, prevention is focused on that individual kid in the classroom. And then at other times, it's focused on the entire community. And the same thing is true in recovery. You're working in both levels at the same time. Questions or anything anybody wants to add to that? And I can go to the chat and see what I see.
As people think about that, I just want to, for people who are not monitoring the chat, we put up information about PARI. It's the Police Assisted Addiction and Recovery Initiative, and there's a link that Chris put up for it as well, and other people are talking about that in the chat. Thank you for doing that. And there are others across the country, so you can look at those as well.
That's great.
Mhm.
Okay. So so engagement is really a place where prevention and recovery intersect, right? So where prevention, so one is just figuring out who's who in both communities. Who's in my recovery community in my community, and who's in my prevention community? And in many, but not all, communities, I always call them tables, right? There's a table where people are sitting. Now, people in recovery services may be sitting at the same table. It may be a human service task force, right? It may be a coalition of some kind, but be assured in many communities, there's a table. And so the question is, who's at that table and how can I find them and how can I locate them? And I actually end up doing a certain amount of, I like finding things for people. And so I do a certain amount of tracking information down for people. And you know, the way it is now with the internet, it's amazing what you can track down with a simple Google search, especially when looking for prevention services in a community. Establishing rapport among and between groups. And that's exactly what we're doing, right? We have prevention, recovery, people doing both, and we're having dialogues with each other. Providing information about risky behaviors and strategies. So what does reducing risk look like in recovery, and what does reducing risk look like in prevention? And are there any commonalities there? And how do those things cross over? Because we're both trying to reduce risk.
Mhm.
This enlisting commitment to change, right? Behavior change on an individual basis, on a community level basis, and also underlying addressing issues of race and health inequity, because those are those underlying factors, you know, poverty, discrimination, racism, that add to the risk of both individuals as well as communities. And those have to be tackled head on.
Yeah. Carol, I would add that, you know, I think our go-to piece in terms of engagement many times and collaborations is the internet, because we all have smartphones. Most of us have computers and that sort of thing. And I would caution us just to go to that. Again, we're talking about being outside of the box, which requires that I forgo all of this thing that you need to come to me. I'm going to call you. I want to engage with you, but you need to come to me under my terms, under my roof. We need to get out of our comfort zone. We need to immerse ourselves in communities, including communities that have been marginalized, right? As has been said before. The COVID exposed the disparities that have existed, have been developing on this continent for a very long time.
Yeah.
And it also exposed all of the disparities as it relates to technologies. And so if you're only reaching out to people, if we're only reaching out to people via technologies, then we'll miss people who have been further marginalized, right? And so we want to get out of our offices and look for collaborations in not the usual spaces and places. So when people ask me, what does that mean for you? For the communities that you work with, Janet, I say, you know, go to recreation events, to festivals, to sporting events, to where people congregate in cultural pieces, right? In faith-based institutions, you know, that have community-based activities, get out into the community. That's the way that we're going to establish and sustain relationships that are durable over time, right? And sustainable over time. If not, we're just going to be responding to the people who can respond back through email or through, you know, a phone call, you know, that sort of thing.
That, I think that is so well stated. And, you know, I have done a lot of consultation, you know, on the prevention side with coalitions around membership recruitment. And often the reality is it takes a lot of work to build relationships. It takes a certain amount of outreach. I have a colleague who, you know, did a lot of prevention work, and you know, 3 times a week he had lunches in his calendar to go and just hang out, whether it was coffee or a sandwich or whatever, just talking to people, because he knew that was the heart of engagement. And the truth is, it's not easy necessarily. It's doable, but it does mean getting out there and making yourself available, and then having some uncomfortable conversations sometimes about Are they going to understand what we do? I mean, for preventionists, and anybody on the phone can tell me, sometimes it's like hard to describe what the heck it is we do so that people can understand us in just general terms, you know? And how do I communicate that to someone? And I'm sure on the recovery side, you know, do we have any common, and what is this person who's doing upstream strategy going to care about the work I'm doing in recovery? And what I would say, there's so much to care about and so much that can be done collectively that it's worth sort of taking that risk. So I'm so glad that you said that. I think that's fantastic.
And I would encourage the supervisors in the room, if you have staff and they're trying to do this, please don't think about billable hours in the way that you traditionally think about billable hours, right? Because engagement, disparities have taken hundreds of years to develop. You're not going to get it through an email, or we're not going to build this overnight. It takes time. Relationship building, as Carol just said, takes time, right? So if you're a supervisor, be flexible and help people, push people to say, how are you engaging with community, that sort of thing. And to the uncomfortable feelings, listen, you're going to come into communities where people are going to confront you and they're going to say, where have you been? And what do you think? We know what we're doing. And so if we go in with a mentality of telling people what to do and not listening patiently and sitting with discomfort, then we're going to miss the boat, because we're going to say, well, these people are not interested, or they're just not ready, or they just don't understand. And again, when we point the finger to community, there's 3 fingers pointing back, my mom used to tell me.
I love
right?
that.
And pay attention to yourself and what you're doing and what you're not doing, Haned, because many times what you have is judgments based on misinformation. So sit with discomfort, sit with people who are upset and frustrated. They have a reason to be, right?
Yes.
87,000 people died in a 12-month period last year of opioid overdose deaths. People are upset and they have every right to be, right? And the system hasn't worked well for all people. For some people, yes, but that's not the only people that we're providing services to, right? So we're going to come against that discomfort, sit with it, prepare for it, talk with colleagues, speak in supervision. Don't let that stuff creep out when you're engaging with communities, because if it does, that has the power to break those engagements and those relationships.
It's great. It's wonderful. So individual engagement. So we talked a little bit about this, which was this indicated. So because they target individuals, indicated prevention interventions are working with the same people that recovery support services may be working with, right, before they're in recovery. And so, and it's a very porous, right? It may be that it's not like, okay, now someone's in recovery and they're in this box, right? And they're never going to go into this box. It's very porous. And so having an understanding and talking about the strategies and what you're doing with people who may be at risk for overdose or other kinds of harms is one of those engagement parts. And the other one I really think too, especially for parenting programs. And, you know, I think for preventionists, it's like, where am I going to find, you know, parents whose kids are more at risk? Well, working with, you know, a recovery services group who wants to provide parenting and skill building anyway to the people in recovery and saying, we would love to do a parenting youth program with both, is a great opportunity to be able to collaborate. There is a, you know, group that you can work with. So it's on the individual level. Also, so who am I connecting with in prevention? So one, individuals in recovery, definitely. But also the recovery movement, you know, who are those, who are the people who may be the storytellers, the people who have a sense of what recovery means? That was one of my biggest ahas when I started many years ago working on a prevention and recovery training, was that recovery wasn't a state of being, as I originally thought. It was a movement. It has people and passion and advocacy, and it's huge. And to understand that and connect to that and see, gosh, what do we have that would be supportive and helpful for that? So you can connect and reference to the recovery movement. And whether you look at one of the resources on it, or you look to see what kind of recovery services do we have, engage somebody who might be providing them and find more information out about what they do. The recovery support services, as we talked about, and recovery community organizations. invite them to the table, have them sit down. And I'm sure they have resources and passion and information, and they have a lot of information about a group of people that they are serving that you want to serve, right? Because we want to serve the entire community. And the entire community includes people who are in recovery, and they can be a great asset. That's the other piece too. So that's who, prevention can really connect from the individual to the movement to the organization as well.
Carol, I would add to that piece on the
Yeah.
recovery. We all know that, hopefully, that Recovery Month is September. There's a bunch of rallies that happen all over the country. Connect to those. Some of those are small,
Yeah.
some of those are huge. The national rally is happening in Houston, Texas on the 18th of September. I'm coming to it. I'm speaking at it. A lot of people come from all over the country, right? But there are many other local small gatherings, right? That people have, not just rallies. And believe it or not, the state of Rhode Island has a rally that they do behind the wall for people in prison. How cool is that?
Wow.
Right? And when did they start that? They started, Rhode Island does a really good work in terms of, and you can look at RI-CARES, RI Cares, around that movement and how they started that. But those rallies and those activities really help people to connect with one another, because people just don't go to listen to people talk. They break bread. They bring resources, information tables, and that's a perfect opportunity to engage with the recovery community and beyond, right? Because people from treatment come as well, people who do intervention, people from across the continuum, and these rallies are growing as we speak. And there's also an International Day of Recovery as well. The founder of it is going to be at the Multiple Pathways Conference in Florida. So there's a lot of opportunity through those rallies as well.
That's great. I saw a prevention coalition. What they did is they worked with, in that particular community, there was an interfaith council, and they worked with the interfaith council to have one Sunday and then a Saturday with the interfaith, where every synagogue and church and faith community would have a recognition of people in recovery and celebration of recovery. And they did different kinds of activities, and it was really to show that people in recovery, and this is normal, this is part of every day, and this is to be celebrated. And it was organized by the Prevention Coalition in the community. So there are things that for Recovery Month you can also do as on the prevention side as well, and building relationships. So I love this. So this is sort of the idea of community engagement. And I think this is sort of a philosophy, but I really believe it. A prevention prepared community is a recovery supportive community, is a healthy community, right? And I can also switch it. A recovery supportive community is a prevention prepared community, is a healthy community. So we're all working on those conditions and the idea, and you all had it when we did the what do they have in common? It's about wellness and health. And those are the aspects that we have in common. Whoops, and I think, if I'm not mistaken, so connecting, so this is around connecting recovery. So what do we connect recovery to? Well, one of the things I was thinking about was the tables in the community, right? Where are those tables where people are sitting and talking about substance related issues? The indicated populations, the changing conditions. What are the goals there? It may be about reducing stigma. It may be increasing access. There may be some goals that the recovery community has in working on conditions that the prevention community can really get behind. But if the prevention community doesn't know that that exists or that's going on, they're not gonna embrace it or take it on. And I think sometimes this happens just because of lack of connection, right? Lack of, oh, I didn't know you existed and that you were working on that kind of reform, or you were working on that and we're working on this. So I think that really tapping into who's doing this work in this community, and there's a lot of help and support you can get, And I think what Haner said is, you don't want to completely rely on Google searches. You want to go and talk to people and find out sort of who's doing what and what's going on. But I'm sure you can find a table where there are people who are sitting, and you may already be at this table. Mm-hmm. You may be sitting at that very table.
I wanna share this. I think that sometimes it's an issue that comes up that's particular to your region, to your local area that comes up that provides the opportunity for collaboration. And sometimes it's a national issue. And, you know, when I think about, let me just be clear, when I think about doing recovery work or any work along this continuum, I cannot talk about it without talking about mass incarceration.
Yeah.
And there's an opportunity for prevention to collaborate with recovery. Upwards of 80%, depending on where you live and who you're working with. People who are in need or identify being in recovery also have a criminal offender record. And we cannot talk about prevention without talking about mass incarceration, in my view, right? Because my world is surrounded by social justice and anchored in that. And wherever I go, it doesn't matter the population when I talk about that system of mass incarceration and what it has done as a response to a problem that has criminalized substance use and mental health issues, as opposed to making it a true public health issue. Everyone in the room says that's true, and I can get behind that. And here's my experience of recovery with that system. And here is how it continues to affect me today. Opportunities to collaborate there, right? Read Michelle Alexander, The New Jim Crow, if I didn't say that the last time. If you're not into reading a book, look at the 13th on Netflix. It's all about the 13th Amendment and mass incarceration and the opportunities that exist for us to come together and collaborate and connect prevention to recovery and vice versa. There's a lot of interest in doing this, not just from the perspective of prevention and recovery, but even sectors of the criminal justice system are coming around and saying, as we said earlier, it's time that we do something about this. We cannot arrest ourselves out of this problem. So there's a lot of opportunity for connecting with folks around issues as well.
So incredibly well said.
Mhm.
All right.
There's a
So
lot of information that people put in the chat
Yeah.
around more, around RICARES, around other states who are doing this stuff. Thank you for doing that. Faces and Voices of Recovery, all of that. Thank you for sharing all of that information.
let's see. So what's the amount of time, Chris, for the break?
Yeah, so I think we were gonna do 7 minutes again, so we'll come back at 32 minutes after the hour. So
Excellent.
10:32 Central, 11:32 Eastern. What is that? 8:32 Pacific. Yeah, so 32 minutes after the hour.
32. Okay, thanks. Enjoy your break.
All right, I think we can start to bring people back into the room. We're at 33 minutes, so past the hour. And so Carol and Hanir, whenever you want to start back up, feel free.
All right. I know it's interesting how quick breaks go. So this slide is, sorry, this slide is just sort of a summary, and I like it because when I'm thinking about prevention and recovery working together, it's sort of a shorthand. So on the, on the black arrow, you've got sort of prevention and the different levels. You've got engagement, which is in the middle, and then peer support. And it's sort of where substance misuse problems are active in a community and where we build and maintain wellness. And so it's together in this engagement within the community that we're working together. And I think we've said it, but I think this makes for, I did not create this, this was created by a colleague of mine, but I do think it's a nice way of sort of showing that at the center of both is community, and not to let the differences that we have sort of getting in the way of working on what we have as sort of collective goals. Anything you want to add to that, Hanir?
No, I don't have anything.
All right, so here's my question for you. So we've talked about, and we're going to do this also as a quick chat, but from your perspective, and this is where it matters the most, right? It matters what you see, and from what you've heard between recovery and prevention services, where are those opportunities for collaboration? Does anybody have any sense of opportunities that you see in your work? So we've still got some great examples of resources. So any places where you could see prevention collaborating with recovery and recovery collaborating with prevention? Does anybody have any ideas? Schools, okay. A plan to do a lot of work, coalitions, yep. Courts, that's interesting, yep, they could work together. Needs assessment, AmeriCorps members, youth, healthcare system, youth programming, universities. There's a lot of different settings. Juvenile, I began in our own organization by having prevention recovery chats on Zoom. That's great. And that's that beginning of relationship building and just engaging in small ways. Harm reduction based in prevention coalitions, critical linkages. I do prevention work frequently collaborating with recovery organizations on events. So there's a stage or level of collaboration, which is sort of you bring the lemonade, I bring the cookies, which is just like saying, we're going to show up at each other's events and we're going to support each other. And as we're doing this, we're going to figure out other ways of collaborating as well. And here's the thing, it's not about perfection, it's about progress. And so you're going to start somewhere. And as that relationship grows, you're going to find other places where you can collaborate. Faith-based and non-faith-based groups, yes. I think faith-based is actually a really interesting place for both recovery and prevention. It's sort of a space that they both can reside in and have a relationship with faith-based organizations. Departments of Health and Human Services. All right, health fairs. Yep, I've been to many health fairs where I've met people. We did some faith-based forums educating on addiction treatment recovery. Yeah, and let's say you're going to do that. Let's say you want to do a forum and you want to do an education on prevention, treatment, recovery. Having somebody who represents the recovery community and talking about recovery and recovery services rather than the preventionists doing it is just fantastic. Local law enforcement. These are all great ideas. So Hanir, any place where you've seen prevention and recovery work together?
Yes, in all of this stuff around opioid overdose deaths, right?
Yeah.
At the community level, there's a lot of synergy in people in recovery and prevention working together, and recovery organizations working together. in this space that I was talking about earlier. When I mean space, I don't mean the actual physical space, but in the space of working on issues of policies, right? Including criminal justice, those sorts of things, around community resources and healthy communities. And many times the main topic is not even recovery or substance use. It is wellness. It's just, you know, healthy foods. It's coming together for, you know, people, for the betterment of communities based on what communities are interested in doing. And they may not come up with substance misuse or issues of recovery initially, but once you collaborate, those things bubble up because there are needs in the community.
And I think what you're saying too is really interesting. You may not need to sort of start with, I'm from this silo and you're from this silo, but you can start with, you know, I'm seeing this issue of stigma. You know, are you seeing the issue of stigma? Let's work on stigma together, right? What are those? And I think stigma is something that is, you know, hurts everyone. And I think that it's something that definitely everybody can work towards and work on. And it takes, again, a lot of effort to sort of reduce stigma and stigmatizing language and all of those pieces. And it can be a real rallying cry, I think.
I'll give an example, Carol. You know, we are working here in Massachusetts on a number of initiatives, but one of them is on preventing problem gambling, right? With an emphasis on issues of disparities. And a lot of people, in terms of the engagement that we have done at the community level, a lot of people don't see gambling as an issue. It doesn't mean that it isn't an issue, and some people do see it as an issue. So the engagement there has to come from what are your interests, right? And when people give their interests, they're very much in line with preventing problem gambling. It's just coming at it from a different perspective and allowing people to say what their priorities are. And obviously we have funding, we have priorities, but when people, you know, say something like poverty, well, that's connected to gambling, right? When people talk about unemployment, that's connected to gambling. When people talk about incarceration, why? Because we have research that says that people at high risk of developing a problem with gambling have been incarcerated, are men of color, make or earn less than $15,000 a year, you know, all of those risk factors, right? So we're not there saying to people, you must work on our issue. We're there saying, what are the issues in this community? We want to be able to partner with you. And by the way, we have information about this thing called problem gambling. And then most people say, yeah, I know about that. Or I've seen that in action, or I have a family member thereof, or I'm concerned that my kid spends way too much time in front of a computer. I don't know what he or they are doing there, right? So it's coming at it from a really flexible position, right? As opposed to imposing our views on communities, because that hasn't worked. It has never worked.
It has never worked. I think that's fantastic.
And someone asked, Stacy asked, sorry, what's a silo?
Oh, a silo. That's a great
Okay.
question.
Mhm.
Yeah. So when I think of the actual word silo, you know, and people who are in the Midwest, because I always think of, you know, grain silos being, I mean, I'm sure we have grain silos in Massachusetts and New York. So I don't mean to be, you know, not stereotyping the Midwest. But it's a silo, which is where you stack all of your grain. And so when we talk about silos, it's imagining that I have like a silo, a bucket of prevention and a bucket of recovery and a bucket of treatment. And people become very rigid within the framework that they're working on. And it's hard to go across and work and make connections between people who are working in connected fields. And so that's what a silo is. It just really means you're within the field that you started. You could say silo, bucket. Bucket doesn't sound as nice as silo. So that's what a silo is. It's a great question. All right. So here's some, and we talked about these, right? Here's some additional opportunities. So we talked about stigma. We talked about opiate overdose. And this is interesting because, you know, we talked about changing community conditions, partners in recovery and their children. We talked about supporting each other's public policy. So whether that I want to do something about incarceration or I want to do, well, I'm trying to think of a public policy. I want to make sure that people get access to naloxone, sharing information and promoting wellness. These are all opportunities to collaborate. And again, I think this idea of just starting somewhere and having the initial conversation and just engaging a person and having a discussion. And then you don't know where it's going to end up from the time that you start that conversation.
Mhm.
So my question is, has anybody, if you're from prevention or you're from recovery, has anybody been successful at sort of having work with, if you're prevention with recovery and if you're recovery with prevention? And Stephanie had a better example of silos. No. So anybody have any examples of being able to? Yes, Stephanie does. So anybody want to put any quick example in the chat? So we've got some people who've got experience. You've done training together. Exactly. Marijuana prevention program. One thing that has changed my mind, so many people I have met with negative perceptions about addiction, is talking about the effects of the addicted brain and thought. We've been both prevention and recovery bureau at our agency, and we work together all projects. So we are making, yeah, it's interesting. So that's another thing too, is if your state government, and I'm wondering if that person, some of the state services around substance misuse, prevention, treatment, and recovery are organized around recovery systems of care. And so you get this natural synergy. And so it's promoted sort of, at a state level as well as at the community level. Problem gambling focused. Partner with treatment services to collaborate on events for Recovery Month, enlist youth and people to speak in schools struggling with substance abuse. We also give prevention presenters. Yeah, I think that's great. So there are examples and things that you can do. And I think the biggest thing when you're trying to collaborate is do something that's doable for you, something that's actionable. Collaborating with somebody you haven't collaborated with, sometimes it's like, yes, I know I need to do it, but there are all these challenges and things that can easily get in the way, both personally or sort of work-wise or professionally. And so we're gonna look at that for a minute. So
let me say something here regarding something that comes to mind. When working with the recovery community, I have found that many folks in recovery, they say, I want to get back. So I want to go somewhere and speak to an audience about my story, about what's happening with me. And I want to help young people primarily, is the conversation, preventing them from going down my path, right? So I'm going to talk to them about my recovery story. Be very careful with that. Be very careful with that. And here's why I say what I say. My recovery story is not a very good prevention story, not to speak to young people about, right? Because here I come. I dropped out of, or pushed out of middle school, never went to high school, ended up in prison and jail, came out, got a GED while in prison. Now I have a PhD. Now I have a job. I consult with federal projects. I'm doing really well. I own my own house, my car, I have a retirement. I'm doing really well, right? In recovery. And some people take that, well, I can do that too. Be careful with those stories. I understand the need to want to contribute, give back, provide a story, a face to recovery, that recovery is possible. But the adolescent brain works in a very specific way, and some stories get away from us, right? So be careful with that. I'm not saying that we shouldn't put people in front of other people to talk about issues of recovery, but we should be very careful, because I know for a fact that my story is an outlier. That's not right. That's not common amongst people in recovery. And so we need to be careful with that. The other piece that I would just mention here briefly, in terms of bringing people together and collaboration and thinking about how we do things together. And it's good to see all of the stuff that has been put in the chat. I would say pay attention to issues of what time of the day you meet with people, where you meet with people, what language you use when speaking with people, making it accessible, and not just languages in terms of the differences between English, French, Spanish, those sorts of things, but accessible language, right? That people can understand, as opposed to to that language that just fortifies these silos, right? That keeps them in place. Because when I speak in acronyms and I speak in ways that other people cannot understand, then that has an impact on that as well. So I wanted to mention that because of what just Stacy said in the chat. Know your audience, right? And
Yeah,
know the people that you want to engage with.
and I think the point you made about telling your story, I think, and I think your experience is what I've seen in the research too, especially for kids who are more high sensation seekers, kids who naturally want a thrill, that listening to a story like that actually has a reverse effect. But if you're a preventionist and you have somebody who's in recovery and they're really passionate about telling their story, how do I tell them, wait, that's not really going to work? So I think if you're building relationships with recovery, having examples of other ways in which they can contribute and other things, and making sure that they understand, so that it's not like you're saying, yes, you want to contribute, but no, sorry, that's not. And I think preventionists sometimes are worried about having that conversation because they recognize that that might not be appropriate, but how do I tell this person who wants to be involved and help me educate? How do I tell them that that may not be the best approach? And I would say, don't let that situation get in your way of reaching out and figuring out things that you can do together.
And thank you for that, Carol, because someone did that with me. You see, I was one of those gung-ho people who wanted to speak with young people in that way because I really wanted to make a contribution. Now, my mentors in my life helped me to understand that. And then I went, okay, I got it. But it was through a relationship, you see, conversations. And then I got it. And now I'm the one that is, having conversations with other people in recovery and say, here are the options, right? Options, plural, for you to make a contribution. Let's go through those and think about what are the pros, what are the cons, what are the best opportunities based on your story, what's your fit and what's your passion. Once you have that conversation, you do education with people, they go, I got it. I got it. Because people, they're intelligent, they're being straight-faced, that sort of thing. And that doesn't mean that people don't get upset, because initially I was taken aback. I said, what do you mean? What do you mean I can't, right? But it is possible.
Yeah, and it goes to, and I think in prevention too, you also have this tension between what the research says is effective and what people's common sense tells them. My common sense tells me, and I've been on the planet, and this is I should be right, and I totally understand that seems like it should be right, but that's not what and then when you talk about things like research, it's like, well, who are you, with college educated, to tell me about what works in my community? So there's always sort of some of those dynamics that go on in communities. And so I think it shouldn't get in the way of having those conversations and figuring out the right person to have that. The other thing you might do is start, if you want to reach out to someone in recovery, find out something they can do for you. Find out what you need from them to a certain extent, and the asset they have that you want to bring in, and that might be a nice way of doing it.
So a piece that Chris put in the chat, which is really important, recovery messaging training, right? The reason why I don't get up in front of groups these days and say I'm an addict is because I've had training. So when I speak about myself, I talk about myself as being in recovery and what that means for me and what that enables me to do. See, I've been trained in terms of a recovery messaging. And so if you're collaborating or when you're collaborating with folks in recovery, that sort of thing, having conversations about what type of recovery messaging training is available, accessing it, having people go through that. So it's not just you reinforcing this notion of a well-delivered and thought out recovery message that's grounded in eliminating stigma, reducing discrimination, not using terminology that can be offensive and or confusing to people. And that's some of the best training that I've been to personally, right? When I sat there and I took it in, I went, oh, that makes a lot of sense, because it's connected to what we call stigma, which is basically discrimination. So thank you for that, Chris. Faces and Voices of Recovery is connected to that, and your state and local recovery organizations should have training around recovery messaging.
That's great. And I'm sure that's something that if you wanted to, it could also be something that you could provide for like a coalition, I'm sure, if you wanted to educate all the members of a particular coalition about that as well. Here's some of the ways we've talked about, right? Role clarity, like what do you do and what do I do and what's your role and what's my role? Language, and I think this is the biggest one, right? Language, how we talk about things. Preventionists have a challenge. I have a challenge talking about prevention in ways that don't sound like jargon, and is accessible to people. One of the smartest things I ever did is I needed to go somewhere to talk about prevention. And I have an older sister, and she's in engineering of all things. And she sat down with me, and she's really good with language. And she translated what I said to her in everyday speak. I'm like, oh my God, that is so good. That's the way I should describe it, right? But sometimes we're so close to it, it's hard to see what's jargon and what's not jargon. And so language is a good place to start. I mean, then histories, right? The recovery movement has a whole history behind it. Get to understand and learn the history. And prevention has a history too, behind it. And it has influences from different parts. And just like kind of coming from different families, you sometimes develop different cultures in reference to that. So, you know, it can be challenging sometimes to sort of start to understand each other's culture. But it's something that's definitely doable. And so, you know, these are things we've already talked about, right? Tips for collaboration. So they're founded on relationship building. Years ago, I remember reading this story about, it was a really large company and they were targeting domestic violence. And this gentleman who ran this big company invited 5 of his other CEO friends. You can tell what time it is because it's men and not, no women are included. So it was a while ago. And anyway, and when asked about why they did this, he goes, you know what? I like these guys. I like meeting with these guys. And we were talking about it and we thought, let's do something. But it's really these guys that keep me coming back doing this work. So it's at the heart of it. It's relationship building, the shared, and I can't emphasize it enough. When I went and did, you know, talking sessions across the country about collaboration, the biggest thing that came up was language. How do you talk about things? And even within prevention, between, you know, working downstream versus upstream and the language that's there, it's really important. And starting and just saying, how do you call things? And what does that look like? Intentional. This is the other thing too. Collaboration doesn't happen by accident. There's a certain amount of readiness that you have to have for collaboration, and there's an intentionality that you want to have for relationship building. Now, that doesn't mean intentionality doesn't mean that you're not just going to network for a while, but it does mean that you need to put the thing in your schedule and you need to see each other X amount of time in order to have that relationship form. So there's a certain amount of intentionality. Benefits all parties. It can't just benefit one. And this is what I love. Not one size fits all. I think one of the things I love about collaboration too is you never know what you're going to come up with. You know, as that relationship builds and grows, you don't know where it's going to go. And it's not the same because each time you have it, you're dealing with different organizations. And I keep on saying this, it's about progress, not perfection. You know, I am the least perfectionist I know. And I like not being a perfectionist because I realize that it keeps me motivating to try because I don't have to be perfect at it. I can just make little baby steps of progress and then it keeps me staying motivated. So I'm a big believer in that. The other thing too is it's sometimes in collaboration when we have grant requirements and you're talking to your project manager and you've got to fill out a report. And there are all of these things within the domain of the work that you're doing, you know, and you're not, maybe your funder's not going to give you brownie points for sitting down and talking with the recovery people, right? That may not be something you get brownie points, but it doesn't mean you shouldn't try to do it. And it doesn't mean at times from all of the kind of requirements that we have to lift up our heads and say, what else can we do in reference to wellness and health in this community? And maybe I'm going to do something and it doesn't quite fit into my action plan, but I'm going to do it because I know it's going to have good benefits in the end. And so sort of stepping back from that action plan that you have and what the funder is looking for and asking those sorts of questions and figuring out where can I put this in, I think is also really important. So Haner, anything you want to add on that or anybody else?
I would just say continue to feel comfortable with feeling uncomfortable. Engagement requires that. Not everyone's going to agree. You're going to hear some difficult things. It's okay. That's a part of the process. That's the thing that I would add.
I think that's great. And for any of those who are, people who really don't like talking to strangers, and it's just like, I have that sometimes, and I have had meetings on my, a list to do. And I just had to convince myself it was just about doing it, not how well I did it, because I just was like, felt sick to my stomach going, I really don't want to make this call. I know I'm supposed to make this call, but it feels uncomfortable. And sometimes I think you're right. It's just getting through that. And then the next time it's not going to feel so awkward. I think that's great. So that leaves us. So if you want to take a minute, if you want to write any kind of personal action step, you want to reflect on what you've heard in the training about prevention and recovery, and any kind of one action step you could take if you're in prevention, recovery, or both, or something that you learned in the training that you want to act on. And so this is just for you. This is just sort of for your follow-up, and for you to take a moment and do that. And there we go. And so thanks everybody. So that's our last slide. And I really want to thank Haner. You were a joy to present with. And so thank you so very much. And thanks for the opportunity.
Thank you, Carol, Chris, Callan, and everyone else who's provided support. Carol and I get to be in the forefront of this, but we have a team of people, right, working on all this stuff. And so the National Center as well, all the people who have been involved. Thank you very much. And once again, I put it in the chat, but I'll say it out loud. Thank you for all your questions, your comments, your pushback, your critical thinking, sharing of your resources. All of that makes this what it has been for me. It's been a pleasure to be with you. And thank you so much.
Thank you.
Mm-hmm.
Oh, here.
Carol, can you go to the next slide?
Yes, I can.
Perfect. Thank you. Oh, one more. All right. So just for everyone here, anybody who's attended these 2 sessions, we're going to have a follow-up series of learning labs that you can attend in just a moment. Once people kind of slow down, thanking everybody, I'll put the link to the learning labs into the chat. It is an application process because we only have 60 seats. So unfortunately, it's not going to be big enough for everyone, but if you have interest in attending, please do. So I'm putting that in the chat right now. I will also be sending out a follow-up email with where you can view the recordings of session 1 and 2. I'll look through the chats from both sessions and compile a list of resources. There were just great resources throughout the training, so we'll have lots of links coming your way. As well as in about a week or so, maybe 2 weeks, that you can, you'll receive a certificate of attendance for attending these 2 webinars. And then one last piece, I know we're right at 11, but Carol, if you can click to the next slide. For those of you who have a smartphone handy, and I will email this out as well in a link so that you can take our GIPRA. And so the GIPRA is just a way that you can evaluate this training and let us know if you enjoyed it, if we should be doing more of this work. So if you have a smartphone handy, you can take it out, aim your camera at that code, and a small bar will pop up on the top of your screen. And you can click that bar and it'll take you to a very short 2 to 3 minute evaluation for today's training.
It's linked in the chat also, Chris, if people don't have their phone.
Yes, so yes, Callan put the link in the chat. And we will be sending out all this information because I realize we're at the end of our hour, or 2 hours. So I'll send this all out in a follow-up email as well. So if you have the opportunity to join us for the learning labs, we'll have 4 sessions that'll take place over the course of the next 2 months, where you can engage with other recovery or prevention professionals and go a little bit deeper with the content that you've learned about today and really dig in and actually start doing some of the work in your own community. And a deep, deep thank you again to everyone for spending this time with us over the last 2 sessions. It's really meaningful that you paused life and joined us to learn a little bit more about how we can all together create healthier communities. So we really, really appreciate that. And I think with that, we're going to call it a wrap. Like I said, you'll get more information in an email, so hold tight. It'll come out sometime probably early next week, I would guess. Look for that email from us to all of you. Thank you so much.
Thank you, Chris. See you soon.
Yeah, see you in a little bit, Hanir. Thank you.
All right, bye.
Thanks,
Hi,
Callan.
Amir. And
Hi,
I did
Callan.
save the chat, and I will make sure that I download this.
Yes,
recording.
someone asked if we're gonna share the chat with them.
Yeah.
Yeah,
all right. See
perfect.
you later.
Yeah, yeah,
Bye. Thank
cool. Thanks. Yeah, Callan, I'll pull out resources so we don't have to do the whole thing because I did that for session 1.
Oh, awesome. Okay.
Yeah, so I figured I would just type up in a Word document, kind of all of it and send it to Cindy.
Yeah.
And when she gets back, then we can figure out how to disseminate
Okay.
everything. It's a lot of information. It'll be a
Yeah.
big email.
It's good though. It's helpful.
Yeah, great. Well, I appreciate all your support and help today. It was fantastic. I think we tackled the Q&A really well. So,
Yes.
all right. Well, I'm going to log off. Have a great day.
You too. Bye-bye.
All right. Bye-bye.
Oh.